Good morning, everyone, and welcome to UMHealth online webinar. Thank you for joining us. I'm Theo from Department of Orthopedic Surgery, Sports Injuries and Arthroscopic Unit. I'll be moderating the first session. It is my pleasure to introduce Dr. Sugesh, who will be speaking on knee preservation surgery, an increasingly important area in helping patients to maintain joint function and also delay the need for joint replacement. We also have a Q&A session, so please feel free to post your questions in the chat. And after that, I'll be handing over to the PITS team for the second half of the session. So Dr. Sugesh, if you're ready, over to you.
Yeah, thank you, Prof. To share my screen. I hope my slide is visible to everyone.
Yeah, it's all good.
Okay, so my name is Sugesh. I'm from Orthopaedics UM, talking about knee preservation surgery. Basically, just trying to share some of the surgical options that are available for patients who are young, active, and have a degenerative knee, or someone who is possibly at risk of developing a degenerative knee due to some injuries at a young age. So I'll just dive right in. What is knee preservation surgery? So it's not one type of surgery, but it's one or a combination of surgeries where we address four key factors of knee joint health. And you will hear me saying this throughout the talk, which is alignment, ligamentous stability, meniscus, and cartilage restoration. So the primary aim here is trying to avoid or delay arthroplasty and prolonging the life of the native knee of that person. And this topic is become increasingly important nowadays as we see highly active people even in your fourth and fifth decade, and you have younger patients who are presenting with early degenerative knee symptoms. And looking at the graph on the right here, we're trying to keep patients in the green zone as long as possible in their life. So even if they go into the yellow zone, they are in the older age group and hopefully not into the red zone where they go into like revision, knee replacement and whatnot, which has its own set of complications and risk. So probably a lot of us will be very familiar with this kind of X-ray we have seen in training, whether it's medical school or housemanship or whatever, right? So this is young patient, typical medial-sided joint space narrowing, and probably a lot of us will think that this should eventually end up with this kind of result. But is there anything we can do for these patients to prevent going into arthroplasty? And that is basically the whole premise of knee preservation surgery. So why do we want to preserve the knee? Like total knee replacement is an excellent surgery, has a very good clinical and functional results in a lot of patients. But if you really look at the details, like this is a very large registry analysis of more than 40,000 total knee replacements. And if you look at the 10-year survival, those under 65 and more importantly, those under 50, you look at the survival rate is going down and down and down. So especially less than 50, your survivorship is only about 86% at 10 years. So meaning that, when you're 50 or 60, you probably need to undergo another surgery for that. So this is just another paper looking at the risk of revision and the lifetime risk of revision in a male patient who has a knee replacement between the age of 50 to 55 is almost 30 over percent, and this is a staggeringly high uh, uh, number, and you probably should do something different to avoid this kind of surgery in the young patients. So moving on, what are the pillars of knee preservation surgery? Like I mentioned earlier, we look at mainly these four main factors, which are alignment, which is for most people should be neutral or within anatomical limits, which I'll explain in detail later. And it's probably the most important factor. And if there is malalignment, we can offer something called as an osteostomy surgery. Number two is ligamentous stability. If you have a chronic instability in your knee, that will cause progressive cartilage and meniscus wear. So in this case, we repair or reconstruct if there's a deficiency in any ligamentous structure in your knee. Thirdly is the meniscus. For your knee to to work optimally, you need an optimal amount and quality to preserve the underlying cartilage. And if you're deficient, then we can do something called as a meniscus substitution or transplant. And finally, cartilage repair reconstruction. And this can only be considered if all the above has been met. And these key factors are listed from 1 to 4 and in order of importance, meaning that alignment is the most important, followed by ligament, meniscus, and finally cartilage. So I'll try to go through each and give an example of some scenarios. So starting off with alignment surgery, the key surgery here that we use is an osteotomy surgery. So osteotomy surgery is basically realigning the limb so the joint axis goes through the center of the knee, and this helps to redistribute the forces across the knee. So if you look to the picture on the right, this is a classic lower limb axis. And if you draw a line from the hip to the ankle, and that should typically pass in the center of the knee. So when it passes the center of the knee, that will cause equal force distribution across the knee between the medial and the lateral side. And you see on this image, the white line is actually passing on the medial side. And if you calculate, this patient has 6 degrees of varus malalignment, and hence this patient will have increased forces on his medial compartment, which will accelerate wear in that particular compartment. So this is just a case to illustrate the osteotomy surgery. This is a very classic presentation. Middle-aged man, 45 years old, is an avid runner, presenting with medial joint pain. His ligaments are otherwise stable. So in this X-ray on the right, if you drop a line from the hip to the ankle, you can see it's passing through the medial side of the joint. So we go through the 4 factors that I mentioned earlier. His alignment is in varus, his ligaments are stable, his meniscus is intact, his cartilage has diffuse kind of wearing, which is not amenable to any repair reconstruction. So what can we do for this young patient to optimize his knee health so he doesn't have to undergo arthroplasty too early in life? So this is what you can do, is a knee osteotomy surgery. So it's basically a high tibial osteotomy, and you can see now when that red line is dropped from the hip to the ankle, it's passing through more to the central of the knee, and this will help to uh, reduce the stresses on the medial compartment of his knee. So why does osteotomy work, or how does it work in the malaligned knee? And I think this image here really captures the power of osteotomy surgery. And this is a computer modeling study looking at articular cartilage contact pressure. So on your far left here is a healthy knee, the center is a varus knee, and the far right is a varus knee after osteotomy surgery. And if you compare the healthy and the after osteotomy, you can see the after osteotomy there's even lesser contact pressure than in the healthy knee. So you can really offload that particular compartment. Uh, uh, and there's significant reduction in the cartilage contact pressures, and this is even without doing any cartilage surgery. So when we plan for osteotomy, we need to do a radiographic analysis. So this is kind of how the lower limb, in the far left, they all have certain angles that are within certain anatomical limits. Uh, so we usually measure this, and from there we can find where the malalignment is, and from then we can plan which bone that we need to correct. So classically in a varus knee, this is a lot of times from the proximal tibia, and on the far right you can see this is planning of how we do the cuts of the osteotomy based on our measurements and uh, correction angles. So this is how we used to do it, and fortunately these days we have modern planning software. So planning softwares allow us to be more precise in our measurement of our angles and also planning of the surgery. And you can see this picture B here. We can virtually do the osteotomy doing the software itself. You can use this to simulate the osteotomy, and you can see from various knee we can make it straight, and we can plan how much we exactly want it to be in the end. And in this one, you can see the planning was actually for a correction both on the distal femur and the proximal tibia. And in the far right here is an X-ray that you can see it's actually 1 year, and you can see the comparison between the planning and the final result, which is almost similar. So this software allows us to be more precise nowadays in doing this surgery. So pushing on further, like how can we transfer this plan into the OR table? So we can, based on those software, they can allow us to print these special guides that we can use during the surgery, and it allow us to execute the plan that from the software and do it exactly how we wanted to do it in the patient. So does osteotomy work? So the most common studies, they look at survivorship, like in uh, how long does it take to the patient to convert to a total knee replacement. So this is a study from Canada looking at more than 600 osteotomy surgeries between 2002 and 2014, and you see the 10-year conversion rate is about 21%. So that means that about 80% of patients will be, having osteotomy surgery will be, don't have to undergo the TKR even at 10 years. So you can successfully delay a total knee replacement for up to 10 years in about 80% of the patients. And they found that the most important thing is how bad is the OA when you do the HDO. So this is something that commonly tell patients who just wait until it's really bad and then you do a total knee replacement. But sometimes if we intervene earlier and do a correction, we can actually prolong the life of that knee. How about return to work and sports? A lot of these are young patients. And if we look at this study, about more than 1,000 patients, mean age about 46, almost 90% return to sport, and almost 80% actually return to the same level. So a lot of them are actually runners or even playing high impact sports like football, and they're able to return back after doing an osteotomy surgery. So it's a very durable operation. So this is probably the most controversial part. Back in the days, people always say that after an osteotomy, then when you convert to a total knee, the total knee is not as good. But if you look at these recent studies from 2011 to 2023, they compared those patients who had total knee, primary total knee, versus someone who had total knee after an osteotomy surgery, and there was no significant difference in their outcome scores. And this was followed up to 6 years, and they were equally same. So the old adage that if you have osteotomy surgery, your total knee will be not great is no longer true, especially with modern planning softwares and instruments. So sometimes osteotomy surgery alone is not enough. This is a young patient who presented with medial knee pain and chronic ACL tear with instability for 10 years. If you look at his lower limb alignment, he is in varus as well, if you see that line here again. And on top of that, he has instability. So if you go through our factors, 4 factors that I mentioned earlier, alignment is in varus, ligaments is lax. He had a meniscus which were repairable on an MRI, which I did not show here, and his cartilage just showed diffuse thinning. So in this patient, what we did was a combined ACL reconstruction with osteotomy and a meniscus repair. So by addressing all these factors, we give him the best chance of prolonging the length of his native knee joint. And these are fairly complex surgeries, and with the help of technology nowadays, like 3D planning software, we can use that to better execute our surgery. So making very precise cuts and tunnel placement and screw placement to avoid any conflicts during surgery. So these have really improved our outcomes with this kind of surgery. And similarly, using 3D printed guides, we can plan and then bring it into the OR and then execute these cuts precisely. So moving on to meniscus preservation, which is the third factor I mentioned in the 4 factors for knee joint health. And we know that meniscus plays a very important function in reducing the stress of the knee joint. And we try to repair the meniscus as much as possible in all cases, but sometimes the injury is too bad that repair is not possible, that the patient ends up with a subtotal or a total meniscectomy. And this can have disastrous complications. This is just a case to illustrate the point. This is a 45-year-old guy who presented with knee pain. He had some meniscus procedure 10 years ago. His ligaments were stable. If you look at the picture on your left, it shows a very small rim of meniscus that is left. And you can see the severe wear of his cartilage on the tibia and also on the femoral condyle. If you look at his alignment, it's already falling into valgus because he's losing the cartilage on his lateral side. So once again, we look, he has a valgus alignment. His ligaments are stable. He has loss of lateral meniscus. He has this diffuse cartilage wear. So in this kind of patients, he probably presented a bit too, 10 years is probably a bit too late and with some already grade 4 lesions on his cartilage. But if this patient presented earlier, uh, the, to, the way that we can save this joint is to do something called as a meniscus transplantation. So this is another uh, technique of knee preservation surgery, especially for patients who have lost near or total meniscectomy. And these are usually frozen or fresh meniscal allografts, which are matched between the donor and the recipient before transplantation. So this is just an illustration of how the procedure is done. We get the meniscus either with bone or soft tissue from the tissue bank, and then this is prepared in the back table as such, and then the whole procedure can be done like arthroscopically through mini incisions, and we can pass that meniscus allograft through small incisions into the knee joint. And this last picture down here showing the meniscus held in place with multiple sutures, and you can see how it sits in between the condyle and the tibial plateau to help to redistribute the forces between those two joint surfaces. So does this even work? So back in the day, it was thought to be an experimental procedure and was not widely practiced. But this is now we have more than 30 over years of data, and this meta-analysis of more than 1,000 patients show there is significant improvement in pain and functional outcome in this select group of patients, and the overall mean failure rate is still fairly low for a salvage procedure like this with only 10%. And the authors concluded it's a safe, reliable, and no longer be considered experimental. And does it protect your cartilage? This is another long-term study from China, up to 14-year follow-up, and they looked at joint space narrowing. And if you compare someone who had meniscectomy and someone who had an allograft transplant, it's almost half the rate. So we can definitely slow down arthritis in this group of patients by doing a meniscus transplant. And how about return to sport? These are once again young patients. They want to go back to playing some form of activity. So it's almost 80% is able to return to sport. And if you look at the type of sport, these are like even high impact sports like soccer and running, and a very low conversion rate to partial or total knee replacement, about 1% only in this systematic review. So lastly, I'd like to briefly talk about cartilage repair and restoration. There are many options of cartilage treatment based on the lesion characteristics. And in this talk, I will primarily talk about the restorative option, mainly when we're dealing with very large cartilage lesions where, the option is either arthroplasty or a salvage procedure. So what kind of salvage procedure we can do for really large lesions? And this is just a case, once again, to illustrate the point of a very young female who had a condition called osteochondritis dissecans, where the cartilage and a piece of bone actually separates from the underlying condyle. She had an attempt of cartilage repair but failed, and she presented with persistent pain. If you look at the X-ray here, on the lateral side, you can see a little bit of defect on the bone here. And on your far right, you can see this arthroscopic picture of a very large cartilage lesion on a lateral femoral condyle. And fortunately for her, her alignment was neutral. So once again, we look at the four elements. Her alignment is neutral, her ligaments are stable, her meniscus is intact. So her only issue is basically a large osteochondral defect. So in this case, we can proceed to just do a cartilage restorative procedure. But if there's a malalignment or a loss of meniscus, then the patient would need to undergo all of those together. So I would like to talk about osteochondral allograft transplantation. It's probably not a very common procedure done in Malaysia, but it is one of the strategy that we can use to treat these large cartilage lesions. And the benefit of this is it gives you an immediate restoration of subchondral bone and type 2 hyaline cartilage. And in the past, it's probably not used a lot because of graft storage and availability back those days due to the graft processing and availability. You need to do the surgery within 7 days from harvesting from a donor. However, as the tissue banks learned better storage methods, and now they have increased the time to implantation, and they have excellent success rates. And a picture of the right is just an example of a plug where you can see a nice cartilage with subchondral bone. So these are just some examples of how we can treat these really challenging cartilage lesions. On the medial condyle, you can see a very large defect here, and we can prepare and put a large graft to restore the congruity of the joint. You can also restore in complex regions like in the trochlea, like this, and also in the patella, when you have large lesions in the patella. So the outcomes have been pretty promising. This is a systematic review, 10-year survivorship, almost 80%, significant improvements in patient-reported scores at final follow-up. And although the reoperation rates are a bit high, but all the patients significantly improved in clinical and functional outcomes. This is looking at doing this in even more severe diseases. This is a bipolar lesion. You can see they are actually replacing almost the entire lateral tibial plateau together with the meniscus. And even in these cases, really technically challenging cases, 10-year survivorships is almost 70%, which I think in a young patient is probably worth a shot. And also the return to sport rates have been really high. These are really young patients, about 30 years old, almost 75% return to sports. And if you look at the type of sports they are playing, it's all high impact kind of sports. And more importantly, if you look at the survivorship analysis, like despite playing all these high impact sports, the survivorship is almost 90% at 10 years. So it's a very durable operation and something that we can offer for these young patients who otherwise will undergo an arthroplasty. So what are the challenges for us here in Malaysia? I think most of these grafts are procured from tissue banks in US, so it's very expensive. We have limited availability, and the surgery needs to be done within 28 days because the longer you wait, the chondrocytes in the cartilage transplant eventually will die. So we're trying to do, so when it's coming from US, there's always a logistic and timing constraint. So what are some future directions? I think ideally we should have local tissue banks so we have more accessible grafts for patients, and this can reduce both costs and the logistic implications. I think regenerative medicine will be a big space to watch, especially because as surgeons, despite we repair and reconstruct the structural issues, the OA will still progress at a cellular level, and we don't really stop that. We just slow down the effect. So if we can find a way to stop this at a cellular level, that will really push the envelope in knee preservation surgery. And finally, with AI and machine learning, I think we can really utilize that to use our large database and find which are the best patients to do osteotomy surgery or an arthroplasty, and also can use in surgical planning to optimize our osteotomy targets. So with that, I'd like to summarize. I think I just showed a few knee preservation surgery techniques, and they all can reliably avoid or delay arthroplasty in the right patients, and modern technology have improved our precision and execution in these techniques. Careful patient selection is still the key, and it's crucial to address all the 4 key factors that I mentioned earlier. And alignment is still the king, and sometimes osteotomy alone is enough in a lot of these patients. And with that, thank you.
All right.
Happy.
Thank you, Dr. Sugesh. I think it's a very insightful session, and also we have understand a lot from what you're trying to tell us. We don't seem to have any questions from the audience. So I guess maybe Dr. Sugesh, what do you think that the patients that has been coming to us, are they a bit too late when they present to us? And also some of our patients, they can't hear us. Can you all hear me? Yeah. And some of our patients, they are quite resistant, and when we tell them that they need an osteotomy, how do you think we can overcome these challenges?
Yeah, I agree. I think uh, one of the aim of this talk is actually to improve the awareness. I think a lot of patients, when you tell them that you want to cut the bone and realign, they feel it's a very aggressive type of surgery. But with technology, a lot of this surgery are done minimally invasive, and a lot of patients can be weight bearing like within 6 weeks or 2 months after the surgery. So I think it's just improving awareness to the patients. I agree with you, in Malaysia, a lot of patients have a hard time convincing them that this is a right surgery, and a lot of them just live with the pain and, eventually undergo arthroplasty. But I think, yeah, the key is to increase awareness of the possibility of having osteotomy surgery.
Yeah, I think that's quite right. Yeah. So I think we are almost time's up for this session. And there's still no questions from the audience. Yeah. Nothing in the Q&A. I've heard, okay, there's a question. I've heard about bone alignment without surgery. What do you think? Bone alignment without surgery, Dr. Sugesh. Are they talking about bone setting that has been quite commonly and commercialized in?
Yeah, yeah, maybe they're thinking about bone setting.
Yeah,
Yeah, but
yeah.
I think if you have a structural malalignment of your bone, like your bone, like I showed in my slides, they form certain angles. You can't really change this without surgery, unless you are, a growing child. And you're when you're in your children, then yes, when we grow, as we grow, our angles of our bone as we grow will change. But as an adult, that angle is set, and it only can be changed through surgery.
Yeah, I think we have to be very careful when we look at all this from the social media. I think it's still quite important for the public, for every one of us to get proper medical treatment. And yeah, I think every one of us will agree that many patients come to us who have seen physiotherapists, chiropractor, or anyone. But I think it's best to get proper treatment. Yeah, bone alignment, we will probably need surgery. Yeah. And we have also probably a last questions. Can we not harvest meniscus or cartilage from the brain dead patients? Yep, sort of like a donor.
I think with permission you can, but it's probably not as common here in Malaysia. A lot in the European countries, it's donorship is like a presumed consent. So is you are presumed donor unless you specifically state that you don't want. So that's why in those countries they have lots of supply of this meniscus and cartilage as compared to Asia. In fact, most of the stuff that we get is actually from US or Europe. So in the future, I think, yeah, this is something that we should explore.
Yeah, I think there's something that I think we are getting some of them as well soon. Yeah, all right. I think that's all for our session. Thank you very much, Dr. Sugesh, for a very good, insightful session and great discussion. So we'll now move on to the second half of the webinar. I would like to invite our pediatric teams, Dr. Chua from PITS, to take over. Thank you.
Thank you.